Thank you for tuning in to my grand rounds. I'm Taeweon, PGY5. Hard to believe we're already at this stage. Today, I'll be talking to you about cytoreductive nephrectomy, particularly in the context of contemporary management of metastatic RCC, a management paradigm, I think, that has undergone a lot of changes, even over the years that I've been a resident. And I think it's timely to look at how best we can incorporate this as surgeons in this multidisciplinary approach to management of this disease space. And I was personally interested in this topic after a memorable clinical encounter that I think encapsulates the nuances of cytoreductive nephrectomy and the fact that it ultimately integral patient selection and discussions with relevant specialists. To that end, we'll review the rationale for cytoreductive nephrectomy, why we think it might work, not only from a clinical perspective, but also with a growing understanding of the molecular basis of the primary and the metastatic renal cell carcinoma, why the removal of the primary renal tumor may confer oncologic benefits. Subsequently, we'll review the relevant literature surrounding cytoreductive nephrectomy, including discussions around historical perspectives, earlier evidence that shaped the recommendations for this modality, as well as discussions around landmark papers that have informed the use of cytoreductive nephrectomy in metastatic population. And lastly, we'll review what we may consider optimal candidates for cytoreductive nephrectomy. I'd like to acknowledge Dr. Soleimani for medical oncology and Dr. Black for their supervision for this presentation. And I'd like to start off with a case. 64-year-old man presents to his family physician for workup of 6-month history of weight loss. This is a gentleman with several comorbidities, otherwise well controlled, who is otherwise felt to be in a pretty good performance status. His astute family physician orders the following CT, abdomen and pelvis, which I'll show you right now. Rewind back. Obvious abnormality, left lower pole large, heterogeneous mixed attenuation mass. Looks like it may even be abutting the adjacent structures. If you look back a little bit, a hint of a small renal vein thrombus as well. Otherwise, no evidence of visceral metastases or retroperitoneal lymphadenopathy. What is not shown here is a concomitant CT chest that was done. Actually demonstrates at least 4 to 5 lung nodules that is suspicious for a metastatic process. In summary, this gentleman presents with probable metastatic renal cell carcinoma. He is seen by a urologist, and given his otherwise fair performance status and oligometastatic disease, cytoreductive nephrectomy is contemplated. But of course, however, his disease progresses quite rapidly, enlarging lung nodules getting larger, as well as evidence of a new para-aortic lymphadenopathy. He is seen by medical oncologist, and decision at the time is to instead proceed with systemic therapy given his poor risk disease on the basis of neutrophilia, anemia, and time to systemic therapy less than 1 year. In the background, he's coming in and out of emergency room with gross hematuria and clot retention. Finally, early December, he presents with hemoglobin of 76. He's requiring multiple transfusions, and he has a CBI-dependent clot retention. After discussions with the local urologist and medical oncologist, primary medical oncologist, it is decided to undergo a palliative nephrectomy. We were able to accomplish this laparoscopically on the emergency slate. We also removed the lymph node that was suspicious for dissemination, as well as concomitant cystoscopy and clot evacuation. He does well postoperatively and goes home on day 3. Pathology indeed confirms clear cell RCC, high grade, with renal vein thrombus and a positive note for pathologic staging T3A and N1. 6 weeks postoperatively, the patient starts combination immunotherapy. However, there's a delay due to a non-operative complication. Treatment of metastatic RCC encompasses multiple pillars. Of course, systemic therapy plays a prominent role. Recent population-based data suggesting that overall survival in this metastatic population is improving thanks to the growing effectiveness of the systemic therapies available. In select patients, active surveillance and metastasis-directed therapy remains an option, particularly in active surveillance in patients with metachronous metastatic disease, while selected patients can be monitored safely on active surveillance for up to 15 months. That was based on a prospective trial. Cytoreductive nephrectomy, of course, is a focus of our topic today. I think it's important to acknowledge that the patient group that we're referring to here is patients presenting with synchronous clinically detectable metastases, and the intent of removing the primary renal tumor with the intent of potentially improving survival, relieving symptoms, or delivered after systemic therapy in good responders for possible consolidation. I think it's timely we talk about the evolving role of cytoreductive nephrectomy. The systemic therapy landscape in metastatic RCC has undergone major changes over the last 2 decades, starting with the cytokine-based therapies. And our earlier evidence and the role of cytoreductive nephrectomy in this population has been framed by 2 representative trials published in Cytokine Era. We'll talk about this later in this presentation, that initially informed a survival benefit associated with patients receiving both surgery and interferon-based therapy. But of course, shortly thereafter, you have explosion of targeted systemic therapies characterized by the introduction of targeted therapies that are more effective than cytokine-based therapies. And this has in a sense, blurred the role of cytoreductive nephrectomy in this metastatic population, contributing to its decreasing use, at least based on population-based data. We eagerly awaited the results of CARMENA and SURTIME, the representative trials informing the use of cytoreductive nephrectomy in patients receiving targeted therapy. While it started recruitment in 2010, it took almost a decade for them to publish their findings. I'll discuss why that might be. And of course, it was already outpaced by introduction of several combination-based first-line systemic therapies based on combination immunotherapies. And as a result, we still don't have a good idea of how to integrate cytoreductive nephrectomy in the contemporary immune check inhibitor era. Moving on to why we may, what kind of benefits we may actually reap from offering cytoreductive nephrectomy. I think several hypotheses exist that explaining its benefit. I think first of all, it is this idea that removing the primary tumor provides overall immune benefits to the host, allowing them to restore proper anti-tumor response and warding off potentially metastatic disease. By creating a favorable tumor microenvironment. Secondly, removal of the primary tumor essentially eliminates a reservoir of what we call metastases-competent clones that are typically housed in the primary tumor, thereby preventing further metastases. And lastly, I think this is one that's born out of clinical principle and an example that applies to the case that we discussed is that it has a ability to, or enables a symptom relief, a tumor-related symptom relief. I think to provide the basis for the first rationale and providing immune benefits, I think we have to conceptualize renal cell carcinoma as fundamentally an immunogenic disease. Earlier observation have shaped this rationale as they have observed rarely that there was a spontaneous regression in metastatic disease after cytoreductive nephrectomy, and they thought this potentially was related to the fact that primary RCC confers to the rest of the body a relative state of immunosuppression, thereby removing it restores the body's ability to mount a proper immune response against the disease. And of course, their role as immunogenic disease has been the foundational basis for RCC being systemically being treated historically with cytokines. And now, of course, with the contemporary therapies, including immune checkpoint inhibitors. In fact, clear cell renal cell carcinoma was one of the most immune infiltrated tumor types in a recent comparison of 19 cancer types profiled by TCGA, demonstrating actually the most amount of a T cell infiltration compared to other cancer types. Then we have to recognize the important role of tumor microenvironment in either fostering an anti-tumor environment versus a pro-tumor environment. And immune cells have a very critical role to play in this. And it is hypothesized that the tumor microenvironment in RCC actually favors a pro-tumor environment based on earlier studies from RCC-based immune infiltration profiles, that several mechanisms may contribute to this, including T cell receptor dysfunction, hastened apoptosis through expression of FAS ligand, production of T cell inhibitory cytokines, and of course the T cell expression of immune checkpoint markers that have formed the basis for why we treat them with the antibodies directed at these markers. And this idea that the RCC tumor microenvironment confers a state of immunologic sync, diverting all the necessary player effector cells, memory cells, antigen-presenting machinery away from other sites contributing to metastases. And overall, this forms at least one biological rationale for removing the primary tumor in the setting of synchronous metastases. Moving on to the next point is that the model of understanding the evolution of metastatic renal cell carcinoma is compelling. We know it behaves very heterogeneously, not only in the way it spreads, but also its target organs, as well as the timing and the latency of spread. Of course, we conceptualize metastatic RCC based on their spatial distribution. They can be limited in volume in solitary or oligometastatic disease, but also can be widespread. And our understanding has been aided by this idea that the tumor possesses inherent heterogeneity with islands of tumor clones that can potentially harbor enough alterations to become competent at distant dissemination. And this propensity for progression is ultimately determined by the tumor microenvironment and the selection pressure that is applied to these clones that eventually contribute to their dissemination. And when they sequenced matched primary and metastatic tumor regions, they identify that the metastatic tumors tend to have more homogeneous clones that possess fewer what they determine are the driver somatic alterations. The key of branching in their evolutionary development that contributes to their final dissemination. And we can conceptualize this as an evolutionary bottleneck, meaning it's actually the primary tumor that harbors the key elements. They are the ones that harbor competent clones that eventually become metastatic, thereby providing rationale for removing this and preventing further progression. Interestingly, they have characterized these metastases competent clones. The ones that are being selected are I think, unsurprisingly characterized by elevated somatic copy number alterations, increased proliferation index, as well as their capacity for immune evasion. They've additionally characterized the loss of chromosome 9p and 14q are potent drivers of metastases, particularly in clear cell RCC, potentially representing their role as biomarkers. We can conceptualize cytoreductive nephrectomy in a palliative setting as well. There's a spectrum of tumor-related symptoms that are both local and systemic. I do think that maybe the frequency of symptomatic disease may be underestimated in real life. I'll talk about why this was particularly relevant in discussing a SURTIME trial, a trial that was highly anticipated comparing deferred versus immediate cytoreductive nephrectomy, but significantly under accrued from their target goal. And I think this had to do with the fact, I think one of the reasons was the fact that the tumors had to be asymptomatic, but when the patients were inquired about it, actually, surprisingly, a lot of them described symptoms precluding them from inclusion. Cytoreductive nephrectomy think in select patients with can be offered with the intention of relieving often life-threatening symptoms. I think we saw that with the case with the gross hematuria and clot retention and multiple transfusions. A quick word on removal, the capacity to remove tumor thrombus. I think retrospective studies have demonstrated, or at least suggest that tumor thrombus may be resistant to systemic therapies. And we know also from multi-regional sequencing studies that tumor thrombus in itself can harbor metastases competent clones, thereby providing rationale for their removal. I'll move on to discussions of the literature of cytoreductive nephrectomy. There has been a longstanding interest in this surgical option. I mentioned that they rarely observe spontaneous regression of metastatic disease. I think based on clinical principle, they knew that it can also achieve a symptom relief, but also more observational data that the patients are being treated with a multitude of cytokine-based therapies, the poor performance tended to have primary kidneys in situ. A lot of the earlier evidence in this era was shaped by retrospective non-randomized trials. It's difficult to overcome the selection bias when interpreting the data, as well as confounding and the lack of granularity in enabling meaningful conclusions. But I think the earlier studies at least establish a framework of importance of patient selection. Specifically, in a particular study by Bennett, almost 80% was not able to receive any systemic therapy after cytoreductive nephrectomy. And perhaps reason being that, more than a third of the patient in this group had visceral metastases, quite significant extrarenal disease burden, and very poor performance status. Whereas studied by Falek, a much smaller group of patients studied, but only 2 unable to receive systemic therapy. And they're the ones who initially proposed that they perhaps best to limit cytoreductive nephrectomy in only patients with a good performance status, no evidence of visceral metastases. And interestingly, they provide a threshold for being able to debulk at least 75% of the total tumor burden. We have a pair of high-impact randomized clinical trials that combined cytoreductive nephrectomy with interferon alpha. It's important that cytoreductive nephrectomy was performed in an upfront basis in well-select patients. They had metastatic disease. Their primary tumor had to be resectable, good performance status, and no prior systemic therapy. These 2 independent trials actually used identical inclusion criteria, actually making it amenable for combined analysis. And when they compared the primary outcome of overall survival, there was almost a 6-month benefit to using a combination approach compared to systemic therapy alone. There wasn't a significant delay in their ability to deliver systemic therapy after surgery. A certain portion of patients were not able to receive systemic therapy afterwards due to complications. This was a very favorable group. 20% of them had no measurable disease after surgery. 35% only had lung metastases, I think, which tends to come up in discussions around who are maybe better candidates for this combined approach. And the results from this pair of randomized clinical trials provided level 1 evidence early on in cytokine era that upfront cytoreductive nephrectomy combined with interferon alpha prolongs overall survival in this well-selected group of patients. Of course, this recommendation became quickly outdated with the emergence of systemic therapies, specifically targeted therapies, that firmly established themselves as a new first-line systemic therapy, replacing cytokines. And I think it was initially difficult to integrate how to best offer cytoreductive nephrectomy in this population. I think a lot of that also because of the fact that the majority of the trial population were not your cytoreductive nephrectomy population with synchronous metastases, but majority of them actually had metastases after removal of their primary tumor after a variable amount of time. We have again, several retrospective, non-randomized trials from multiple, multi-institution, single institution, or population-based database demonstrating or suggesting that there is maybe a survival benefit in those that are able to receive both cytoreductive nephrectomy and a combination of targeted therapy that is, of course, not standardized across these studies. So it's hard to, again, make meaningful conclusions around this. Not only that, we don't know how, in what sequence the targeted therapies were delivered. I think it's also important to mention there's a significant risk of bias, particularly in these studies where they excluded patients who were not able to receive systemic therapy after cytoreductive nephrectomy due to disease progression. And excluding these patients, of course, would skew the benefit towards improved overall survival by excluding them from their respective survival analysis. And I think in the end, this really highlighted the need for a randomized clinical trial in this setting. And then CARMENA was, CARMENA fills that the gap in knowledge. It was a New England Journal paper in 2018, randomized clinical trial comparing upfront cytoreductive nephrectomy with sunitinib versus sunitinib alone. It's a good performance status. And everyone had to be eligible for systemic therapy. I'll discuss why that might be relevant. In this non-inferiority trial, they randomized 226 patients to the combination and 224 to the sunitinib alone. This was actually an under accrual. It took over 8 years for the study to complete. And even then, they were still unable to meet their accrual target, but the independent trial committee determined that the results were sufficient enough to published. They found that in overall survival, which was the primary outcome, there was non-inferiority for sunitinib arm alone. In fact, the median overall survival in this group was longer than the combination arm. It's important that the results are published in an intention to treat analysis. So looking at the randomized group of patients, but this might be particularly problematic for this trial because there's quite a significant deviation in people who were randomized to their respective arms. Specifically, the patients that were randomized to sunitinib alone, almost 40 of them actually underwent what was called a secondary cytoreductive nephrectomy. This was not a planned part of the procedure. And the majority was actually in people who demonstrated good response to targeted therapy, and the cytoreductive nephrectomy was thereafter offered by individual clinicians involved in their care. And when we actually adjust for this deviation, looking at the per protocol analysis, looking at people that were actually randomized and got their ascribed interventions, the non-inferiority is no longer met. Another criticism of CARMENA is the overrepresentation of poor risk patients. More than 40% of eligible patients in CARMENA were classified poor risk. They used an MSK model to ascribe disease risk. More locally advanced disease in the patient arm undergoing combination. Also, a lot of disease outside of the kidney. Estimated about 60% of the disease was actually within the primary kidney. And I think at least from the earlier studies from the cytokine era that usually it's the ability to be able to debulk more than 75% of the tumor burden that tends to, I think, provide or at least suggest that it provides more benefits. This is not meant to be a direct comparison, but just an illustration of the fact that CARMENA population was particularly enriched in poor risk. Just comparing them to the risk distribution from other representative trials from immunotherapy, where they have less proportion of poor risk patients and maybe a better trend towards a median overall in their survival in patients that are only getting targeted therapy. Again, this is not meant to be a direct comparison, but just an illustration that this poor risk group was particularly enriched. And I mentioned that the disease risk was stratified according to the MSK model, and I think that also needs to be addressed in this cytoreductive nephrectomy population. I mean, in clinical practice, we use the IMDC model to ascribe risk. And this was specifically validated in metastatic RCC population requiring systemic therapy. Majority of them had actually undergone prior nephrectomy, and so they're in a metachronous metastatic population. And these models were not were validated to predict overall survival based on their risk distribution using combination of clinical and laboratory variables. But these models, even though they're not validated in this particular group of patients with synchronous metastases, these models are widely used in clinical trials and incorporated into various guidelines informing the use of cytoreductive nephrectomy. So I think that's something that we have to, caution as well. I think importantly, these models were also validated prior to immunotherapy. In any event, when we reclassify CARMENA patients into IMDC category, there's a similar distribution in terms of their risk. When they look at the survival in the sunitinib-only arm and in only intermediate risk patients, there's a longer survival is demonstrated, although I didn't include it here, but non-inferiority was not met. I'm just going to circle back to the point about the fact that one of the points, you get 1 point for time to therapy less than 1 year. And how exactly this plays into synchronous metastases population is a bit of a paradox, because just on the fact that they come in with metastases at the same time, does that automatically make them intermediate risk based on the fact that they will be getting systemic therapy, or they may be headed for that? And I think they try to account this in this subgroup post hoc analysis. They looked at where a majority of the patients with one risk factor in IMDC were just simply the fact that they presented with synchronous metastases. Do they have similar survival outcomes in this trial compared to ones who maybe actually have more other manifestations of disease? And in fact, it's actually the patients in the surgery group with multiple risk factors that performs poorly, at least when it comes to survival. We also get a sense that maybe the number of disease, the extent of disease burden outside of the kidney also is a possible prognostic factor. Again, in the surgery arm, the worst survival was seen in a group undergoing combination with multiple metastatic sites. We mentioned that the findings of lung-only metastases are potentially favorable. In intermediate risk patients, they actually demonstrated longest survival, but limited by low number observed. What was really interesting about this post-hoc analysis is comparing the survival between the patients getting targeted therapy upfront and in eligible candidates, the ones who are able to go secondary cytoreductive nephrectomy due to a good response. And this group demonstrates significantly improved overall survival versus people receiving sunitinib therapy and not responding, and therefore not able to undergo subsequent surgery. Of course, this we have to caution against selection bias here, and they're selecting out for presumably more indolent tumor biology that is responding well to systemic therapy, and they're more, as a result, more likely to receive the survival benefit. And also this phenomena of immortal time bias. The fact that patients had to be alive long enough to be considered for surgery. In fact, the median time from their randomization to surgery, if it was considered, was almost a year. This was nonetheless a hypothesis generating in the cytoreductive nephrectomy in patients with good response to initial systemic therapy, perhaps receives further survival benefits, providing a litmus test in people who respond favorably and can perhaps benefit further by offering them surgery. I think significance, targeted therapy alone was not inferior to combination, but I think we have to take into account that the trial was enriched in poor risk patients, actually, in fact, underrepresented favorable risk patient. I think this is really the group that was in question. The poor risk patients or a lot of disease outside of the kidney would have gotten systemic therapy anyway. And I think the reason behind under recruitment is also the fact that the fact that it also took a long time for them to complete the study is that these favorable risk patients that I think we would have contemplated cytoreductive nephrectomy in clinical practice were not represented at all. And I think maybe that reflects the clinician's bias towards, I want them to get cytoreductive nephrectomy anyway. I don't want to risk them getting randomized and not getting the surgery. So I think it's the idea that maybe there's a contributing recruitment bias. But I think it does highlight that perhaps poor risk and or high metastatic burden patients should prioritize systemic therapy. Hypothesis generating finding of secondary cytoreductive nephrectomy after upfront targeted therapy may confer additional survival benefits. And really this raises an important question of, does timing matter and what is the optimal sequence of systemic therapy in relation to cytoreductive nephrectomy. And SURTIME trial was published in 2019 that was designed to address that. This was a randomized clinical trial comparing immediate versus a deferred cytoreductive nephrectomy in metastatic population with good performance status treated with targeted therapy in sunitinib. Their trial design was pretty straightforward. They were randomized to immediate arm. If that is the case, they undergo nephrectomy right away. And with the view towards starting targeted therapy 4 weeks after making sure that there's no progression. If you're randomized to the deferred arm, you undergo 3 cycles of targeted therapy. Check for progression just prior to nephrectomy. Of course, a lot more people not receiving their intended treatment in the deferred arm due to progression of disease. They included a pretty favorable group of patients, but I also discussed that it had to be asymptomatic primary tumor. And I think this specific requirement maybe contributed to their significant under-accrual. They had targeted upwards of 450 patients, but they're only able to recruit 99. These were the relevant findings. So their primary outcome was actually progression-free survival. They couldn't publish their data on overall survival due to under-recruitment and not enough events observed, but no difference in progression between the deferred and immediate arm. Favorable overall survival in the deferred arm compared to upfront cytoreductive nephrectomy. I think what's really interesting is that this exploratory analysis shows that the survival curve splits in those who progress shortly after their randomization to either arms compared to those who don't. And this is somewhat confirmed under this post-hoc analysis. This is looking at these gray bars represent respective randomization protocols, whether that's surgery versus systemic therapy or vice versa, looking at sum of targeted lesions based on RECIST criteria. In the immediate arm, a lot of variability in how they respond. Whereas in the deferred arm, I think there's a general, more a predictable response is observed in this group. And again, this is a group that is being selected for by the fact that they're responding to systemic therapy and likely going to respond further with subsequent surgery. The deferred arm was able to receive targeted therapy for longer duration in general. They actually had a number of single-arm prospective trials looking at the sequence of cytoreductive nephrectomy, particularly in a deferred setting. And this is just a table collecting their relevant disease risk. So when they combined 189 patients undergoing deferred cytoreductive nephrectomy after treatment with either sunitinib or pazopanib, definitely 35% of them not able to receive subsequent surgery. A lot of the unknown reasons, but a big part of it was that they had progressed during targeted therapy. When they looked at the median overall survival across all comers, no significant difference in their survival. but survival is significantly improved when you look at only intermediate risk disease and no difference in poor risk. Just a quick word about the conduct of surgery after targeted therapy. I think the issue around wound complications comes a lot after exposure to systemic therapy. At least the retrospective studies have suggested that surgery after targeted therapy associated with increased wound risk of wound complications. The data from the earlier prospective trials, I just combine them here, report anywhere from 5 to 20% a risk of wound issues, but predominantly delayed healing, and they were not very significant, grade of Taeweon Dindal 1. And it appears reasonable that resuming a systemic therapy 2 to 4 weeks after their surgery likely avoids major wound complications. We're talking about immunotherapy and how they've become now the new standard of care, especially the combination therapies and across all risk groups in metastatic setting. And a preface discussion and how do we best integrate the role of cytoreductive nephrectomy in the multidisciplinary management of metastatic RCC. And it's right now we don't have a good answer because there hasn't been any prospective trials or randomized clinical trials in this setting. A lot of it we're understanding that retrospective studies are at least suggesting that patients being treated with both surgery and immune checkpoint inhibitors have a survival benefit. This is a retrospective study from the National Cancer Database looking at patients receiving both therapies versus ones just getting immunotherapy alone. The non-randomization nature of the study, of course, a selection bias, but the group getting surgery are younger, they have larger primary tumor. A group that is getting just immunotherapy alone, more liver metastases. Favorable survival in this group wasn't reached. In all multivariate analysis, the receipt of cytoreductive nephrectomy was the only independent predictor for overall survival. They were actually able to look at do a subgroup analysis on patients getting upfront versus deferred. Again, it maybe favors the deferred setting, but we're limited in our ability to interpret retrospective data. This is yet another one that was published last year looking at the IMDC cohort. I should also actually mention that they presume that they received the immune checkpoint inhibitor because they had just filtered based on patients getting treatment after 2015, which seems reasonable, but again, it's open to interpretation. This is the IMDC data that half of the patients received nivolumab ipilimumab, so one of the standard management options. Enriched in poor risk disease in the immunotherapy group. Again, this was a non-randomized study. Better overall survival in this group. It's only suggested the findings are definitely not conclusive in confirming the benefit of it, and we really need a prospective study in looking at this. This was a systematic review of a combination of cytoreductive nephrectomy and immune checkpoint inhibitor. This was a fresh out of the GU ASCO presentation. Looked at 8 retrospective studies undergoing combination. The surgical population tended to be younger, have lower liver metastases, lower poor risk disease. They did a landmark analysis at 6 months and 12 months, trying to mitigate the immortal time bias, the fact that they had to be alive long enough to be considered for surgery anyway. Just a quick word on surgery after immune checkpoint inhibitor. This was a single center series. Everyone had upfront immune checkpoint inhibitors. Few readmissions within 30 days. But I think it just goes, the authors didn't report any intraoperative difficulties. One patient was actually able to achieve a pathologic response. There were 2 mortalities, one related to disease, one related to a postoperative complication, but it is being described. And I think when we get into more situations of cytoreductive nephrectomy post immunotherapy, I think at least based on small number of series that has been published, that that it is technically safe. And I think actually a few of them were able to undergo the surgery laparoscopically. Again, the representative trials informing the systemic therapy landscape and current management. I think majority of them also represent a metastatic population. They've had their primary kidney tumor removed sometime before they started their systemic therapy. But nonetheless, there are people that have primary tumor in situ that are getting treated with combination therapy versus sunitinib alone. And their subgroup analysis that show that there are still survival benefits and maybe progression benefits. But really, this is a group that we're interested in. Whether cytoreductive nephrectomy actually provides further survival or any oncologic benefits. And again, we need to look at this evidence. There is a strong need for prospective evidence to determine optimal candidates as well as the optimal sequences of events. That being said, we have trials on the horizon, particularly Nordic Sun. This will be interesting. Everyone gets upfront combination immunotherapy, and if they're eligible for a cytoreductive nephrectomy, then they will be randomized. And I think this will address an interesting point. They will be randomized to cytoreductive nephrectomy or just maintenance immunotherapy. This is a group that's in question, so that if they respond well to systemic therapy, should they all undergo surgery, or can they actually just be observed without it? I think that will address a definite gap in our knowledge. This is a similar design probe trial. Everyone gets upfront immunotherapy, and if they're demonstrating clinical response, then they will be randomized to surgery or no surgery. The last trial is actually looking at upfront combination therapy. One group will pause therapy for 21 days. Whereas the other one in 14 days. So looking at different interval of treatment cessation. I think defining optimal candidates for cytoreductive nephrectomy is limited by the fact that we talked about it specifically in CARMENA, that perhaps the ideal population, the ones with favorable risk and low volume disease, are now well represented in clinical trials. Available evidence for cytoreductive nephrectomy predates contemporary immune checkpoint inhibitor era. And existing models of disease prognostication are now validated in this group, yet it is widely used in our selection of these patients for surgery. We're in need of prospective randomized trials studying the benefit of surgery in this population receiving the contemporary systemic therapies. I think ideal model of patient selection is using a prospectively validated model based on combination, not only clinical or laboratory, but radiologic and molecular markers. And multidisciplinary discussion is the heart is a crux of patient selection. This was a retrospective that looked at whether patients, after they undergo cytoreductive nephrectomy, whether they can be observed on active surveillance. Their argument being that this is probably the group that benefits the most from receiving upfront surgery with a synchronous metastatic disease. And this was a retrospective look at their single institution experience. And in the group that was able to be managed on active surveillance, a few proportion of them had favorable risk disease, not represented in any of these groups that were managed with targeted therapy only, or cytoreductive nephrectomy followed by almost immediate restart of systemic therapy. They proposed that perhaps longer duration of active surveillance with low disease burden, whereas they only have metastases within the lungs or less than 2 criteria based on the IMDC model. Again, the limitations of prognostic models is that none of them have been validated in the synchronous metastatic group. And it is not surprising that individual models consistently underperform when externally validated to a cytoreductive nephrectomy population. I think the problem also arises that not every model is practical. Some of them you incorporate pathologic variables, so can't use that towards pre-operative selection of patients. And also the fact that some models were just validated in non-metastatic groups, so we're looking at different population altogether. This is a new model that was just published last year that combines not only the clinical factors or laboratory markers, but also a few proposed radiologic findings, mainly around describing the tumor burden by number of sites and total burden or evidence of bone metastases. When they ascribe different risk groups, and when they generate this decision curve analysis, actually tends to perform more benefit with this new what they call a screen score compared to just a standard IMDC model in consecutive patients with metastatic disease treated with upfront cytoreductive nephrectomy. I discussed in the earlier discussion around multi-regional sequencing of clones from the primary tumor that develop competence for metastatic dissemination. And what they also found is this observation that there's two different patterns of metastatic evolution, one characterized by rapid progression, and these tended to harbor clones with low intratumor heterogeneity and high genome instability, suggested by their weighted average of copy number alterations. On the flip side, you have attenuated progression. This was marked by quite a delayed latency between metastatic disease, and this was represented by clones with high intratumor heterogeneity and low genome instability. And you wonder whether that represents a way to distinguish whether someone would likely fail from cytoreductive nephrectomy due to their propensity for rapid progression and likely a presence of occult micrometastases that have already occurred, compared to maybe these are the optimal candidates because they already have a latent disease to begin with. I didn't spend too much time discussing non-clear cell metastatic RCC. They're underrepresented in literature, especially in the cytoreductive nephrectomy space, but retrospective studies have suggested that there's perhaps a survival benefit to patients with a metastatic non-clear cell RCC undergoing cytoreductive nephrectomy, but this space is also in need of prospective data. I discussed the management of metastatic RCC, and the cytoreductive nephrectomy is just one way of managing the primary tumor. And I think with the growing role of SABR as well in the management of primary tumor, and there are relevant trials that are emerging looking at the combination of SABR with immunotherapy versus immunotherapy alone in the treatment of metastatic RCC. And the primary outcome is actually looking at a nephrectomy-free survival. I think there's not a perfect algorithm exists in candidacy for cytoreductive nephrectomy. I think it needs to be highlighted that it will be a multidisciplinary discussion. A lot of factors will go into play here: disease risk, patient's performance status, disease burden of disease within and outside of kidney, and whether they're symptomatic. I think there's the retained role of upfront cytoreductive nephrectomy in the following patients. I think this is an important point here. After removal of their primary tumor, their metastasis is amenable to either surveillance or metastasis-directed therapy. I think everyone who falls outside of the group should prioritize systemic therapy, and if there's good response, they can be considered for deferred cytoreductive nephrectomy. To conclude, cytoreductive nephrectomy remains an integral component, what is inherently a multidisciplinary management of metastatic RCC. Patient selection is key, and I think we await prospectively validated markers of patient identification and selection on who would benefit from this multimodal approach the most. I think the survival data is the strongest for patients getting deferred cytoreductive nephrectomy after initial demonstration of response to systemic therapy. And the clinical trials investigating the role of surgery in the contemporary systemic therapy era are maturing. Thank you, everyone.